Hi, thanks for joining us. My name is John Klatt, and I'm going to show you first aid for gunshot wounds for yourself and other victims. And I'm going to give you some tips to help keep you alive should you ever find yourself in a gunfight. You might find yourself at a gun range, at home, a police firefight, or a full-on military conflict. The end result is the same. When somebody's been injured by gunfire, the steps that you take in the first few moments may mean the difference between life and death. Medical care may be 5 minutes to an hour away. In this video, we're going to show you how to provide care in those first few moments. But first, safety. Scene safety. Scene safety is not the safety of your victims, but your own safety. You can't provide care if you have been shot or killed. Safety is environmental conditions. It could be rain, snow. You could be in 120-degree heat. Are you in the city where there's lots of vehicles, buildings, and bad guys everywhere? Are you in the deserts of Iraq or Afghanistan waiting for pickup? Once you realize the scene is safe, the next thing you need to do is triage. Triage means to sort or to prioritize. How many victims do you have and what level of care do they need? In approaching each victim, you want to assess 3 things: bleeding, breathing, and movement. As you go through each victim, you prioritize what level of care they need and how serious it is. When you find a victim that is not bleeding, breathing, or moving, the chances are that they are in cardiac arrest or their heart has stopped. The local guidelines are that compressions to ventilations is 30 compressions to 2 ventilations when doing CPR on people. The problem is that if somebody is in cardiac arrest secondary to trauma, the likelihood of resuscitating that person is very low, and that person should have a low priority. You do not want to be spending a long time doing CPR on somebody when several other victims could be using your care. Now that you know the steps of triage, let's get started. As I approach the scene, I need to make sure the scene is safe. Again, we're looking through the 3 signs. Is she bleeding? Is she breathing? And is there movement? Obviously, she's moving, she's bleeding, and she's breathing. My first priority here is going to be to control bleeding. This looks like a high-velocity wound. In high-velocity wounds, it's any round that travels more than 2,000 feet per second. That's most of your military rifles and one 5.7 pistol. So I'm going to treat this patient right away. You want to introduce yourself and make sure that they know who you are and what you're doing. Hi, my name is John. She knows me already. And so I'm going to make sure that she's not going to pass out. I'm going to look for the mechanism of injury that might help me decide whether she has a neck injury or not. But our priority here is bleeding. She's going to bleed to death if I don't control bleeding right away. This is a typical blowout kit that the guys in Iraq use. It's got gauze, bandages, scissors, and some other things that I'll show you later. So my first priority in controlling bleeding for Genesee here is to put some gauze over this. One of our big concerns is body substance isolation, and that is making sure that you don't get blood on yourself. If you can wear gloves, that's the best way to do it. If you can't, you might have the victim here put her hand on the injury and hold that up in the air, because the first 2 steps in controlling bleeding are direct pressure and elevation. Now, if I don't have any gloves and I need to get my hands bloody, I want to make sure that I don't have any cuts, because if I have any cuts, then I'm really concerned about this victim's blood here. I don't have any cuts. I'm not going to use any gloves. So I'm going to start by using some 4x4s or some gauze and put some direct pressure over there. I'm going to hold pressure on this wound and see if I can get it controlled. If I get it controlled, I'm going to go ahead and use some roller gauze and bandage this up. So I'm going to roll this around. One of the mistakes that are made in people using roller gauze is they roll too much and they put it too tight. You don't need to put a lot of gauze on here. All you need to do is put enough to control bleeding. So I'm just going to put enough, and once I control bleeding, that's it. You can cut it off, tape it, pin it, whatever you want to do. If I can't control bleeding here, I've got direct pressure and elevation. The second way of controlling bleeding is called pressure point. Underneath the bicep here is an artery called the brachial artery. It's the main supply of blood to her arm. So what I can do is go underneath her arm and find the brachial artery and pinch that off. I can hold that and see if I can control bleeding. A lot of people ask, how do you know you get the brachial artery? And the only answer is you feel around, you push in until you control bleeding. If I control bleeding, then I can move on and check Genesee out for other injuries, head injuries, and do what's called a head-to-toe assessment. The third phase of controlling bleeding, if I can't control it with direct pressure, elevation, and pressure point, is to use a tourniquet. In just a few moments, I'm going to show you how a tourniquet is used. In rural areas and in combat, we do utilize tourniquets. So after this wound is taken care of, I'm going to treat Genesee for shock. I'm going to lay her down and lay her all the way down and start a head-to-toe assessment. It's very important that you look for both entrance and exit wounds. Many times we'll treat wounds that are superficial on the front and we'll miss the exit wound in the back, especially with high-powered weapons, again, over 2,000 feet per second. The entrance wound can be small, but the exit wound can be great. Of course, in this subject right here, she's not screaming and yelling, and that certainly is a concern. When people are yelling and they're in pain, it makes it more difficult to treat them. You just have to deal with it. Sometimes, if you can talk to them, try to talk to them in a nice, calm voice, you'll help calm them down and make the situation better. It's always good to try to include them in the aid that you're providing, like when she was holding her hand and providing elevation. And just so you know, in a triage situation and safety, as I mentioned earlier, just because she looks so sweet and innocent doesn't really mean that she's that sweet and innocent. Always make sure that the scene is safe. As I mentioned, the final step in controlling bleeding, if you can't control it with direct pressure, elevation, and pressure point, is using a tourniquet. A big mistake that a lot of people use is they'll use something small like this shoestring. They'll go ahead and put one knot in here, run a stick through here, tie another knot, and then they'll rotate that stick until they control bleeding. And indeed, that will control bleeding at first. But what's going to happen with the string is it's going to cut into the skin and it's going to start to bleed again. So that's not the best way to do it. The best way to provide a tourniquet, if you don't have a store-bought tourniquet, is to use some roller gauze. I like to use 3-inch roller gauze. 2 inches and 1 inch just gets too small. So I'm going to pull some roller gauze out, and I'm going to roll it around here. Now when you apply a tourniquet, if the bleeding is down here around the thumb, you want to put it as close to the injury as possible. So I'm going to go ahead and rotate this 3-inch roller gauze around, and then I'm going to take a stick, and I'm going to rotate that around, and I'm going to leave some roller gauze. Now what I want to do is I want to start twisting on this stick, and all you're going to do is twist the stick until you control bleeding. And once you control bleeding, then use the rest of the roller gauze to tie it off. And we're going to make a tie. And if you have to leave this person and you're going to cover them up, that is treat for shock, which I'll discuss later, you want to make sure that you use some of the blood and put a T on their forehead. That will indicate, if somebody finds this victim, that they have a tourniquet somewhere on their body which is not exposed because you've covered them up. So this is one way of providing a tourniquet. Now the guys overseas in Iraq, they have these tourniquets right here. Each man has 2 tourniquets. They're responsible for taking care of their own bleeding. Should someone be shot in a gunfight, as I mentioned, the scene is not safe. No one's going to be able to run to their help. So in applying your single man tourniquet, all you have to do is place this on here, make it tight, and then twist. And you're going to do that until you control bleeding. They used to say to release tourniquets every 15 minutes, release them for a couple of minutes. The problem is that blood pressure dropped and a lot of people passed out and ended up bleeding to death. So the new method of applying a tourniquet is, once you apply the tourniquet, put the T on the forehead, and you're going to leave this person or get them ready for transport. You never release the tourniquet. Are they going to lose the arm? It depends on how long and how severe the injury is. In arterial bleeding, every time the heart beats, the blood is going to pump. And so when you're looking, and that's the type of bleeding that we control with direct pressure, elevation, pressure points, and tourniquets. Typical bleeding like scrapes, abrasions, or venous bleeding is slower bleeding and can usually be controlled with just direct pressure. But it is arterial bleeding where you see the blood is squirting out, and that's the type that you need to use 1, 2, or all 3 of these methods. And then once you see that that bleeding is controlled, that's when you're going to stop applying your methods. There's not a rule that goes on. We know that people that are in motor vehicle injuries and they push the knee back, they push what's called the popliteal artery back, and their leg is not getting any blood. The lower portion of her leg sometimes can last 3, 4, even 5 hours. It depends on the condition of the person, the severity of the injury. So you might have 2 or 3 hours to work with. So if medical care is close and the tourniquet is what it takes, then that's what you need to do. It only takes a few minutes for somebody to bleed to death. So you've got to figure, am I going to lose the limb or am I going to lose the whole person? Sometimes a tourniquet is the only thing you can do to save somebody's life. My chief concern with Genesee was that she was bleeding. Now that I've got controlled bleeding here, I'm going to have her elevate her arm and keep it up so it doesn't keep bleeding. Again, if it continued to bleed, we would apply a tourniquet on Genesee, and I'll show you that later. So I'm going to have her, if we have to transport her to medical care, we're going to have her hold this arm up in the air as long as she can. It looks like she's going into shock a little bit, so I may need somebody to hold it up for her, or I may have to do that. Now secondary, when I do a head-to-toe assessment, because she sustained this huge injury right here, it's very possible that she has broken bones in here. In looking for fractures, there's 3 steps we go by. One is mechanism of injury. This high-powered gunshot wound to her hand could definitely cause some of the other bones in her arm to break. So that's number 1, the mechanism of injury. Number 2 is point tenderness. When I go ahead and I palpate down Genesee's arm and I feel for other possible gunshot wounds or breaks, and she screams out and that hurts, that's number 2. That could mean that there's a fracture at this site. And number 3 is swelling. So if either one of those 3 are there and you suspect there's an injury, you want to immobilize it. The important thing about immobilizing a fracture is that if you let her move this arm around and one of her bones in here is broken, which is a fracture, and it moves around, it could cut other blood vessels in her arm and she could bleed internally and we would never know. So what I want to do for precautions is I want to immobilize Genesee's arm. In immobilizing arms that have been fractured, from the shoulder all the way down to the hand, we'll typically immobilize them against their chest. It's the position of comfort. Now there are 2 things that I can use here. These are called triangular bandages. They're very simple to use. These are very multi-purpose bandages. I can use these to control bleeding. I can use them for headbands. I can use them for anything. And when I place this cravat or triangular bandage on Genesee here, I'm going to hold this out and I'm going to take the small end and I'm going to tuck that behind her elbow. So I'm going to bring this all the way up. And then I'm going to bring the other end over and I'm going to tie this behind her head. Now when you're putting a triangular bandage on somebody, you want to make sure that their arm is up high, because when I attach this triangular bandage, you'll see what happens with their arm. I'm going to make the tie on the side instead of in the back, because if I put the knot in the back, it's going to be pressing against her spine, and that's not going to be very comfortable for her. So I'm going to go ahead and put this cravat or triangular bandage on. Go ahead and relax your arm. And now you can see her arm comes all the way down. So if you had put this triangular bandage on with her arm down, you can see that it might drop too far. Now I can take another triangular bandage or cravat, and I can further immobilize this arm. You don't need a cravat. You don't need to buy a cravat. You can use pieces of clothing. I'm going to go underneath this arm, and I'm going to tie this arm down like this and put another tie in the back. And now I've completely immobilized her arm. Another thing that you can do is something called capillary refill. In treating people with injuries, you can see that Genesee is turning white here. It looks like that she's going in shock. That has to do with blood pressure, how big the blood vessels are. If you don't have a blood pressure cuff, like EMS, a quick way to check for blood pressure is something called capillary refill. That is just to pinch the fingernail beds. If you push the fingernail beds in, they should turn white. That means you're pushing the blood away. It should come back or change colors back to red in about 2 seconds. So if I push on Genesee's fingernail and it turns white and I let it go and it takes 3, 4, 5, 6 seconds to come back, I can guess that her blood pressure has dropped and she's going into shock. So I'm looking at her face. She may be breathing heavy. She has a delayed capillary refill. So in treating for shock, I know we need to elevate the arm, but I have controlled bleeding, so I want to treat her for shock. And that is bring her all the way down like this, and then I'm going to elevate the feet 12, 13, 14, 15, 16 inches. By elevating the feet, you'll keep the blood back near the brain where it needs to be. That's why they turn white. That's why they start breathing fast. That's why the delayed capillary refill. And then, finally, when we transport her, we're going to, after we get her in the truck, the ambulance, however you're going to transport her, we can do a head-to-toe assessment. We want to make sure we get a name, the history on her, any medications that she might be on, and take care of her en route to medical care. Let's move on to our next victim. Our next victim, again, we want to make sure that the scene is safe, and we're looking for the three things. Is she moving? Is she bleeding? And is she breathing? And she's doing all three. I'm looking at her leg here, and we can look down here, and we can see that a major artery has been cut with the gunshot wound. So what happens is she's got a major artery that runs down the inside of her leg. It's called the femoral artery. Anytime an artery has been hit by gunshot, whether it be the round itself or the frag that's associated with the bones or glass, as you can see here, the femoral artery is a major supply of blood to the rest of her leg. So because she was hit in the inside of her leg, that femoral artery has been cut. Somebody can bleed to death in 3 minutes' time. So it's very, very important to control this bleeding. That's going to be our priority, is to put direct pressure on this and provide a pressure point. And just like the last person, the last victim, we may need to use a tourniquet as well. So I want to put direct pressure on here. I can also look and see that there's some other damage that's around this injury here. So what I'm going to do to expose this injury so I can find out what's going on here is I'm going to go ahead and cut around. You may not have one of these shears. If you have a knife or something that's sharp, and you can cut and expose this tissue, that way you can see the full extent of the injury here. So as you can see, there's a lot of tissue exposed here. She's probably been hit. Depending on how the gunshot went, sometimes there's just a small hole. Depending on if the bullet has wobbled or a hollow point, or if it's a high projectile round, it may make a big entrance or exit wound like this. This is probably more like an exit wound here, because what happens is the entrance will be a small hole. It'll enter through the leg, and then when it hits bone, the bone acts as a secondary fragment, and so that fragment will blow out like this. And furthermore, when the round goes into the leg, it can be tumbling, it can flatten out and change shape. So the entrance wound is usually a pretty small hole. The exit wound looks like this. So without further ado, we want to control bleeding here before she dies on us. So I'm going to go ahead and put direct pressure on this injury here. And that is the same as Genesee, where we were just putting 4x4s and putting pressure. We're not going to be able to elevate. Now I notice there's another injury here too. There's a shard of glass in her leg. The rule is that if something is impaled inside the body, don't remove it. There are exceptions to this rule, and I'll talk about them later. So I'm going to go ahead and put direct pressure on here. If I can control this and the bleeding stops, then I can move on and check other areas. I can also put some roller gauze on here to hold this in place. So the same thing, I'm going to take some roller gauze and I'm going to wrap this around her leg and control this bleeding. Now there's more than one injury, so I need to control all of those injuries, and I'm just going to tuck this in. Again, when you use roller gauze, all you're using it for is to hold on these 4x4s. If you wrap them too tight, you actually can make a tourniquet. So there's a fine line between controlling bleeding and cutting off the blood supply to the rest of the leg. Now, if I can't control bleeding, the other pressure point is right here in the hip. We have two femoral arteries that go down on the inside of our leg. The way you find them is you can make a thumb in your hip, bring your hand over, and right inside this groove is where that femoral artery is. So if I can't control bleeding, high pressure bleeding, arterial bleeding, I'm going to go ahead and put pressure on this femoral artery, and I'm going to put direct pressure on there until I control bleeding. Once I've controlled bleeding, that's it. I'm stuck here. So if you have another person that can help you, that's the best way to do it. If there's another person that can help, they can put the direct pressure on there, and then I can move on and do the head-to-toe assessment. This right here, this shard of glass, looks like it's getting ready to fall out. If it falls out on its own, that's fine. If you do find anything that's stuck inside the body, a projectile, always pick that up. That's definitely evidence. If it's stuck in the body and it's not going to fall out on its own, you want to secure it in place. That is, take some 4x4s, place them on each side, and roll that roller gauze around. You want to make sure it doesn't move around. The reason you don't want to pull anything out is because if anything's attached or on a major artery or a blood vessel and you pull it out, the victim, could be bleeding some more. So you want to make sure that you don't pull anything out. You always secure it in place. So if somebody was going to put direct pressure on her hip here in that femoral artery and control bleeding, I can move on and do my head-to-toe assessment. I'm looking at her and I notice that she will probably be breathing fast. Anytime somebody goes into shock, the heart rate tends to pick up over 100 beats per minute. So she's going to be breathing fast, her heart rate is going to be fast. I can do the same thing that I did with Genesee. I'm looking at her color on her face, she's pale, clearly she's going into shock and blood is moving down this way. So I'm going to lay her back. Another thing I look at is she's breathing heavy. And if somebody's breathing fast, that's a sign of shock, and then pulse, or the speed of the heart. We don't really check pulses anymore, but the quick way of checking blood pressure is, again, capillary refill. So I can take her finger, push in, push all that blood out, and it should return within 2 seconds. If it's delayed, a delayed capillary refill, that is 4, 5, or 6 seconds, then I can assume that her heart rate is fast, her blood pressure is dropping, and she's indeed going into shock. So in treating people for shock, it's very, very important. I'm going to bring them all the way down. Okay? Now, like Genesee, what we did is we laid her down and we elevated the feet 14, 15, 16 inches. We've got a problem here, though. Because of the injury here, the major bone right here is called the femur. It's the biggest bone in the body. We typically, when we treat people for shock, will elevate the legs. This is one exception to the rule. If you suspect that one of these bones have been broken, the femur, you do not want to elevate the legs in treating for shock, because if you elevate the legs and you move this bone, it can cut and further damage these major arteries and the person can bleed to death. You can put a lot of blood inside somebody's hip. That is, they can bleed inside just by moving their legs around. So this is one time where we're just going to lay Lori down, we're going to cover her up, we're going to do a head-to-toe assessment, and we're not going to elevate her legs. So one sign that you can tell with arterial bleeding is that every time the heart beats, this is a major artery that supplies her leg. So every time the heart beats, it's going to squirt out. And it can squirt out 2, 3 feet, depending on the location. This is a very big artery. The 3 places you're going to see this arterial bleeding is along the inside of the leg, which is called the femoral artery, the inside of the arm, which is called the brachial artery, and then right down here along your wrist is called the radial artery. And the last one that you might see is up here in the neck, and that is called the carotid artery. Carotid artery is very big. If you see that pulsating out of somebody's neck, they have a few moments to live. That's something that you have to act very fast. This is also a major artery. So if you see blood squirting out when you approach this victim, that is your first priority, is direct pressure and tourniquet if you have to. It may mean the difference between life or death for this victim. So if you have to put direct pressure and I'm all alone, we're stuck. We have to sit there. Unless Lori can put pressure on herself. But given her current condition, I doubt if she's going to be able to put that pressure. So I'm going to be stuck. I'm going to have to keep that pressure on her hip. And then when we transport her, it's going to take some more people. Or the only other thing we can do in an emergent situation is if I have to transport her myself, I can get her up, move her into a vehicle, put some more pressure on there, and do this a little bit as we go to the hospital. That's worst case scenario. Again, you really don't want to take pressure off there. So if I couldn't put pressure on there, I would go to a tourniquet. In this case, I don't want to keep putting my pressure, put pressure on the hip and take it off. I would put a tourniquet here. When you put a tourniquet on, it's got to be between the heart and the injury. Again, you want to put it as close to the injury as possible, but not on top of the injury. So if we had to put a tourniquet on Lori here, we would run right along here. Same concept as we did with Genesee. We would roll 3-inch gauze around there, put a stick in there, and twist it, or we can get the store-bought tourniquets where it just attaches. A tourniquet I showed you that goes around the arm works on legs and arms as well. So one size fits all. So Lori, if we had to transport her and I couldn't keep pressure on there, would definitely be a tourniquet victim. In this type of injury, time is of the essence. You've got 3 or 4 or 5 minutes before Lori bleeds to death. So like I said, direct pressure and tourniquet is going to be the most important thing. If you have to put a tourniquet on there to control bleeding, then you can move on with your head-to-toe assessment. Again, the mechanism of injury, and I'll talk about this later, may suggest that Lori has a neck injury or a back injury. And as always, we want to keep her laying as flat as possible and make sure that she doesn't move around or move as little as possible. And then I'll start the head-to-toe assessment. While you're waiting for the ambulance, you're going to periodically, you're going to go from the head to the foot, to the feet, and you're going to be looking for injuries. When we do a head-to-toe assessment, we look around the head, we feel in for gunshot wounds, for bleeding, movement. It's called tenderness, instability, and crepitus as we go from head to toe. I'm going to look in her eyes. The eyes are a great indicator if somebody has a head injury. Typically, when somebody has a concussion, one pupil will be big. If someone is on opiates, the pupils are pinpointed. Have you taken your drugs today? Her eyes are just fine. So we're going to look at her eyes. We look in her ears, in her nose, we go all the way down. How is she breathing? That's pretty important. When people have chest injuries, they're breathing. If they've broken ribs and stuff like that, it's going to change the way they're breathing. There's something called paradoxical equality of movement, and that is, if there's a lot of fractures in the ribs, they may move independently of each other. That is, when Lori breathes in, her chest goes out, but part of her chest sinks down. In that case, she may have an injury to that side of the chest, in which I'm going to treat that. I'm going to again go down her arms and feel for tenderness, instability, and crepitus. So when you palpate, you're actually going all the way down the arms, and you're feeling for broken bones. You're making sure she's got good color and capillary refill. I'm going to do this with the other leg as well. I'm going to go all the way down and feel for tenderness, instability, and crepitus. When I get down to her feet, I'm going to push in on her toenails, given that she doesn't have any nail polish, and look for capillary refill. I can have her push down on my hands. Go ahead and push down, Lori. Go ahead and pull back, pull back, pull back. Perfect. And then do you feel this? Okay. And do you feel this? So what I've done here is I felt for movement of her feet. If she can feel her feet and move them, that further lets me know that she probably doesn't have a neck injury. If she can push down, pull up, and she has feeling. In a victim like this, with this gunshot wound, and she has sustained a neck injury or a back injury, may have no feeling in her feet or her hands. That's important to take note, because if somebody does not have feeling in their hands or their feet, you want to write that down, that they don't have feeling, and you want to mark the time. That's pretty important, because progression over time, people may lose more and more feeling in their extremities. So in a head-to-toe assessment, we go from head to toe, make sure they're feeling, they can push down on your hands, and you make sure that there's no fractures. As always, typical questions that we ask somebody like Lori when we pick them up on the ambulance is how old they are, how much they weigh, are they on any medications. Any type of medical history that she can give us will help us out. She may be on blood thinners, which is going to further exacerbate this problem with her bleeding. She might be a diabetic. So it's important to give us a history of what's going on with her so we can address those concerns as well. So we do a head-to-toe assessment, and then they do what's called a focus history. That is, get a background, find out who Lori is, what is in her past, what sort of medications, and then ultimately will let us know how we're going to treat her from this point and what hospital we're going to take her to. Once the paramedics take over the scene, they're going to again do a head-to-toe assessment. They're going to put her on a monitor. It's called an EKG or an electrocardiogram. They're going to make sure that her heart is working fine, and they're going to immediately start an IV with her. We give normal saline or Ringer's lactate solution to people that have been bleeding, and that will make up that space in their body. So they'll probably start an IV on one or both arms, and they'll start fluid going. Oxygen is always given as well on the ambulance. So she'll have oxygen to her face, she'll have IVs and fluid going, she'll be on an EKG. And then if she needs any pain medications, we can administer through those IVs as well. In combat, there's little packets of morphine that they can give people that are in pain. In the ambulance, there's over 100 milligrams of morphine on the ambulance to help somebody with their pain. It's very, very important, if you're the first responder and providing first aid, that you do provide comfort for people. That is, talk to them, introduce yourself, make sure they know who you are so that they feel more comfortable with you working on them. You don't want to just approach somebody and start prodding around and feeling. You want to introduce yourself, let them know who you are, and that you're there to help them. Let's move on to our next victim. As I approach the victim, I'm going to be looking. I notice that he's face down. He looks like a police officer here, is probably involved in the gunfire. I want to roll him over so I can assess the wounds here. One of the problems with rolling people is that if he has head or neck or back injuries, when we roll him, we can make those injuries worse or exacerbate those injuries. So the better you can roll him, the better. If you can log roll him, that's good. If you're all alone, you have no choice. You have to get him over. A lot of people will say, well, you can't roll him because he has that neck injury. In an emergency situation, you have to get over to assess breathing, bleeding, and movement. So any way you can do it. Some situations where we're in a dangerous area, we're going to have to pick him up, throw him over our shoulder, and run out. People always say, what happens if somebody has a neck injury in a burning building? You throw him over your shoulder and you run out. You're not worried at that point about a neck injury. So with Chad here, I want to roll him over to assess his injuries. I want to make sure that he's breathing, bleeding, and moving, or not bleeding, as the case may be. So if I was going to do this by myself, I would grab Chad by the shirt and the pants, and I would roll him over. But we have the benefit of having someone else help us. It doesn't take a trained provider to help you out. Anybody can help you. They don't have to be a medical person, and you can just tell them what you want to do, but you want to be very clear about the instructions. So because the head is most vulnerable here, I'm going to be at the head, and I'm going to control the head, and Stephanie is going to rotate Chad. So Stephanie, what I want you to do is I want you to grab him by the shirt and by the pants, and we're going to rotate him towards you. So what I'm going to do is I'm going to hold on to Chad's head here, and when we rotate him, I'm going to hold the head and rotate it along with the body. Go ahead and pull him. Okay, go ahead and stop. I'm going to move. All right, go ahead and rotate him. And we're going to move him over, okay? Now once we get Chad rolled over onto his back, I'm going to move my hands and I'm going to support his head like this. Now if Stephanie could do this, she would come down and do what's called spinal mobilization. You want to come down and take over for me? First thing I notice is there's blood coming out of Chad's nose. I'll talk about this in just a second. Now we're going to assess the injuries here. I'm going to do a quick head-to-toe assessment and see what's going on with Chad. Again, I want to address the bleeding first. What I do take note of immediately is coming out of his nose. This is called cerebral spinal fluid. That is fluid coming out of the nose or the ears. It could be bloody and it could be mixed with fluid, kind of a white, milky fluid. What happens here is when there's a head injury or a gunshot to the head, the brain expands. There's fluid around the brain called cerebral spinal fluid. There's no place for this fluid to go when the brain expands. So what happens is it'll come out of the nose, it can travel up through tubes called eustachian tubes and come out of the ears. This is the type of bleeding that you don't want to control. Chad's brain is swelling and blood is getting pushed out of his nose. Clear fluid is getting pushed out of his ears. We want to let this bleed. Your body will reproduce that cerebral spinal fluid. So this is a key and tells us that Stephanie's providing spinal immobilization is very, very important. So now that she's got spinal immobilization and she's looking at his head, I can start a head-to-toe assessment here. I quickly notice that Chad is white, he's pale, he's breathing really fast. I'm going to go ahead and expose the chest here, and I see, and if you can, rip these off. If you have to, cut them off. And what I'm looking at here is looks like a chest injury. I need to expose a little bit further, and I'm going to cut that area. Again, if you have a knife and you have to cut it to expose it, you'll do that. So I'm going to cut and expose this area here. It looks like he's got a bullet wound to the chest here, and there's some blood coming out of it. Now what I notice here is there's a little bit of a red mark down on the bottom. What happens when a projectile hits a person at an angle is if it hits them straight on, it's going to make pretty much a perfect hole. But depending on what that projectile does, whether it wobbles or oscillates or it hits Chad at an angle, it's going to cause a little bit of an indentation. So we know that this is an entrance wound. There's another thing I know about this wound as well. If you notice this black area, this speckled, this is called tattooing. What happens is when somebody is shot from a close proximity, the muzzle blast comes out and tattoos around and causes these black marks, sometimes brown, sometimes black. So we know that this is an entrance wound. We've got a bigger problem here though. Chad is having difficulty breathing, and I can see that there's blood coming out of this. What's happening here is right behind Chad's chest here, his lungs are sitting there, and when the bullet wound goes in, what can happen is that when Chad is breathing, air is leaking out of his lungs and into this space right here. So what happens is the air leaks into this space, it's called a pleural cavity, and it puts pressure on the lungs. And as more air leaks into this space, the lungs start to squeeze closer and closer together. So we need to close this up right away. In essence, what we need to do is make a one-way valve. We need Chad, when he inhales, to put all that air into his lungs and exit out of this bullet wound. Because what's happening is he'll breathe in, the lungs will expand, air will come out. When he exhales, the air goes back in and keeps putting pressure on the lungs. So we're going to do something called an occlusive bandage. There's two ways of doing this. The homemade occlusive bandage is to take a piece of foil. In the military, they said to use your ID card, a piece of wax paper, or anything that you can use. An occlusive bandage is, in essence, a one-way valve. So what I'm going to do here is I'm going to lay this down over his chest, and I'm going to tape this down. And so what I'm going to do is lay anything that will not breathe. Like you can't use a piece of gauze. If you do use gauze, then you'll have to put some Vaseline over it. So I'm going to tape this down on 3 sides and make my one-way valve. The way Chad is breathing is a big concern. If this left untreated, I can tell you right now, it'll be a help wanted sign at his department. Probably didn't want to hear that. That's pretty important that you don't say those sort of things around the victim. The last thing they want to hear is, oh my gosh, you're probably going to die. Hearing is the last thing that a victim loses. So they may be completely unconscious. You may be looking at the scene and saying, wow, this is a bad scene. Keep it to yourself, because the victim can probably hear you. As I said, that is the last thing to go. So what's happening here is as Chad inhales, the air is getting pressed in from his lungs, it's getting pushed out of that hole, and it's coming out through this flapper valve of sorts. And then it hopes that when he exhales, that the air doesn't go back in there. Now, there is a certain condition. What will happen is, if he starts to get better, we know it works. Sometimes there's something called a tension pneumothorax, and what that means is that the lung tissue also has a hole in it, and what's happening there is the air is not only leaking out of this hole and back in, but it's leaking through the lungs into this pleural cavity, and it's collapsing his lung. So what will happen there is his condition will get worse. The only way to treat this is, because you don't know if it's a tension pneumothorax or a simple thorax, as we call this, is to put an occlusive bandage over this and watch Chad and see how he's breathing. I can perform my head-to-toe assessment. And 3 to 4 minutes, I want to, again, take note on how he's breathing. If his condition gets worse, then what I'm going to do is I'm going to go ahead and take this occlusive bandage off and just let as much air come out as possible. If he starts to breathe better, then your occlusive bandage is working. There's another type of bandage too. Again, there's always a store-bought. This is called an Asherman. This is another possibility that you can use. In this Asherman, this is also a one-way valve or an occlusive bandage. And the way this works is, let's say that Chad had a sucking chest wound on the other side. You just take off this seal here, and then what you're going to do is you're going to place this hole right over that gunshot wound. So if this was the hole right here, I would place it right over, and then this is your one-way valve right here. So you can use your homemade one, an occlusive bandage using 3 sides, or you can use your Asherman store-bought and lay it right over the injury itself. Now I'm going to continue my head-to-toe assessment. If Chad starts to breathe better, we know this is working. Again, we're going to start from head to toe, and I'm going to look at the eyes, I'm going to look at the ears. I notice that he's bleeding around the nose here, and he's bleeding from the ear. Again, that's cerebral spinal fluid. Do not control this bleeding. I'm going to search the head to see if there's any bleeding, tenderness, instability. Another thing that we note is sometimes when the lungs get really bad, when there's a lot of air that goes in and that lung collapses, it starts to push the other lung over this way, and that causes the trachea to shift. This is a very late sign. If you see what's called trachea deviation, the trachea is always going to shift away from the injury. So if his injury is really bad and I'm looking at his trachea, it will not be centerline like it is. It'll be over towards me. That's a pretty late sign of somebody that had a tension pneumothorax. So don't look for trachea deviation as the sign for somebody having a tension pneumothorax. Treat that hole just the way I did. I'm going to further look down in the chest. I'm going to look for any broken bones. I'm also going to look for any swelling of the abdominal area here, just by putting some gentle pressure on there, and I'm looking to make sure that Chad is not in pain when I do that. when I do this palpitation of the arm, again, I'm going to go down the arm here. I'm going to feel all the way down. I'm going to feel for broken bones. And again, I can do that capillary refill. Push the fingernail, see if it pops back. Push the fingernail. In 2 seconds, his blood returns. That's a good sign that his blood pressure is doing good. I'm going to look down at the groin area. We can push down at the hips. It's a very bad sign when somebody broke a hip. If somebody has fallen or broken a hip or sustained a gunshot in this area, they'll be in great pain. And the concern here is that major artery, that femoral artery that runs here. So if somebody has broken their hip, you want to be very gentle as far as moving him here. I can go ahead and press in on Chad and see if there's any pain, and I can push down on the hips. I can come down the legs like this and go ahead and palpate all the way down. Should we take off the shoes? It's probably a good idea to remove the shoes if you want to assess the feet and see if there's capillary refill. Now that being said, if Chad was wearing a riot helmet, people always ask, should I remove the helmet? The answer is yes and no. No, if you can get access to his face. If Chad is wearing a helmet and he's been involved in a gunshot, he's fallen, he's had some other trauma, it's great to have that helmet on there because it's keeping everything inside. It's keeping his brains intact. But if we have a problem with getting access to his face, let's say we had to start CPR on Chad, as I mentioned earlier, then we would have to take that helmet off and then do the breathing and everything like that. So sometimes there's a time to take the helmet off, sometimes there isn't. And now, Chad, what I'm going to do is have you roll over here, just like you did when I first found you. Now, when I approached Chad, again, I was making sure that the scene was safe, and I wanted to roll Chad over. This is an opportunity that you have to see if there's an injury in the back. Sometimes what will happen is we'll roll people over, and we'll assess all the injuries on the front, and we won't look at the back. What can happen with back injuries and neck injuries is they can build up fluid in the lower back here called sacral edema. So take this opportunity to assess the back. If I was to pull Chad's shirt up, I would notice that there are plenty of exit wounds back here, and these do need to be treated. Because again, what will happen is if that gunshot went through Chad's chest, it popped his lung, caused that tension pneumothorax. As it exited, it could have been spiraling like this. An exit wound will be worse than an entrance wound. It'll be longer, it'll be irregular in shape, and it can also be from the trauma or the fragmentation from the ribs. So in other words, you may see one gunshot entrance and you might see several exits, because when that bullet or that round goes in and hits the bone and it fragments out, it can fly out of the back and cause several different injuries. So it's very, very important. So seize the opportunity. If you don't want to roll Chad back and forth, when you approach this victim, you can do a quick look and realize that you need to treat this. I can see that he's bleeding here, but it's not bleeding bad, so it buys me some time. The bigger issue is on the front. I'm going to take note that I need to control bleeding back here, but it's not bleeding bad. I'm going to rotate Chad over. I'm going to treat the most important thing, that is the tension pneumothorax, and then when I roll him back, then I can go ahead and treat his back here. So that being said, the back is not a critical area. The big critical area is in the front here. I'm going to go ahead and roll Chad back here, if you'll roll back on here. We've got two segments basically in his chest here. If he has been shot up here in this upper area here, we're certainly worried about the lungs. And so that's going to be collapsed lungs, and his heart is in there as well. Sometimes a round will go right through the heart. There's really no way to fix that. There's no way to take care of that. Down here, a little bit lower than the lungs here, we have his abdomen. That brings a problem. There's the kidney, the liver, the spleen, the pancreas, the stomach, and the large intestines. The problem with abdominal injuries is you don't know what's shared, in these cases, we do is called load and go. That is, if somebody's have sustained abdominal injuries, the only thing I can do is transport Chad as quick as possible. Some of the signs that Chad may have abdominal injuries, of course there may be a gunshot wound here. You never know where that bullet has traveled though, but he is going to start breathing really fast. When somebody's breathing fast or going into shock, their respiratory rate starts picking up about 30 times per minute, their heart rate. If you do want to check the pulse, you can check it right here by the thumb here. It's called the radial pulse. typical heart rate in somebody going into shock like this from abdominal wounds or chest wounds or even leg wounds will be something over 100 beats per minute. So that is, you can check a pulse for about 10 seconds and then times it by 6. So if I checked the pulse and it was 10 times 6 is 60, that's a pretty good heart rate. If it's 20, that's 120, and that's a fast heart rate. So fast heart rate, fast breathing rate, pale face lets me know that Chad's going into shock. When I do that capillary refill and it's slower than 6 seconds, that tells me he's going into shock. So what can happen with abdominal injuries? He can have all sorts of injuries in there. He can shear the liver. He can be bleeding internally. He can get peritonitis. Peritonitis is a problem when people shear organs in their stomach and all the fluids and the bile and the bacteria goes inside the stomach and it causes infection. And that's why transporting this person immediately is very, very important. So is EMS coming, emergency medical service? If they're coming, what they're going to do is they're going to put Chad on a spine board. Anytime we suspect neck injury, we roll this person as little as possible. Again, if it's an emergency situation, we're going to roll them. But if we do have the ability, the time, we can actually put a spine board here in Chad and put him on that spine board, and we're going to tape him to that board and transport him. But if you're out in a rural area and all you have is a vehicle and no way to call 911, you're going to have to drag good old Chad here into your vehicle and move to the hospital. So there's no simple way to do this. If you have to throw him over your back and stick him in the back seat of the car, that's what you're going to do. The best bet is if you can get EMS, if you can get an ambulance or a helicopter here, and they'll have all that equipment to take care of him. If you don't, you do what you got to do. In an emergency situation, you got to make do with what you got. It's called a critical thinking skill. As a follow-up care, if I had treated the chest wounds, any abdominal wounds, or any bleeding that he may have, then I can log roll him, if it's possible, and treat those back wounds, because you don't want them to bleed out. They're not going to bleed a lot, but I do want to treat them. I don't want to take them to the hospital with those wounds exposed. So what I'm going to do with those, just similar to what I did with Genesee and Lori, is I'm going to go ahead and add some gauze there, and I'll just tape them down. And basically you treat them like any bleed, but they're not going to bleed a lot. But it is important to control them. When we talk about low velocity gunshots in the projectile, low velocity is anything that's going to be slower than 2,000 feet per second. When we look at these entrance wounds, it does depend on the caliber of the weapon and also the makeup of that round. For example, if somebody used to shoot a 9mm and it's a full jacket, it'll probably make a nice clean hole. However, the exit wound might be bigger. In some rounds that they have a hollow point or the makeup of the actual round will flatten out in flight. The round can also wobble or oscillate or tumble, and that will also change the wound. When we're looking at entrance wounds, we basically look for a nice round hole. Sometimes when weapons have been fired at close range, they'll actually make a little bit of a scrape at the bottom of that entrance hole. And we can also see sometimes powder burns, also known as tattooing. When somebody has fired a weapon at close range, you can see that the powder burns from the firing of that weapon. The exit wound can be not there, or there could be several exit wounds. What happens is, depending on the round, whether it's a 9mm, a 45, or a 22, can actually enter the body and stay in there and bounce around. 22s and 9mm have a tendency to hit things and move around and not exit. 45s have a tendency to blow through and blow out. That being said, you have not only the bullet exiting the body, but something called secondary fragmentation. And that is, as the bullet enters the body, if it hits a bone and that bone splits up, now you have other frag that's going through. So typically what we'll see is a small hole on the entrance wound, and on the exit wound, it'll be longer, it'll be bigger, it'll be more like a tear. There could be 2, there could be 3, or there could be more exit wounds. It depends on where you're injured. An organ like an abdominal injury can withstand, can have trauma. The trauma can be greater with those abdominal wounds, because what typically happens is those organs can shear open and bleed into the abdominal cavity. Something like a lung can withstand a bullet going through and may fare better. Somebody like a brain injury, like say a .22, which is dubbed the assassin weapon, the .22 bullet, however, can enter the skull and actually go and transverse the skull or follow the skull around. And that kind of pressure causes a high pressure inside the brain, has killed a lot of people just due to that high pressure and that intercranial pressure. In a high-velocity round, which is typically military rifles, anything greater than 2,000 feet per second, you've got that high pressure to deal with. So not only do you have cavitation, which is going to be 30 to 40% of the diameter of that round, but when that round goes in there, that high pressure is going to balloon out, and that's going to cause a greater balloon effect, and that's going to affect more organs. And what can happen here is if enough organs get shared, if enough blood vessels get shared, a person can bleed internally and you won't even know it. You won't be able to treat them because all the bleeding is done inside. We always look for an entrance wound and an exit wound. It's not always obvious. It's not always in through the chest and out through the back. It can be in through the chest, out through the side. Depends on what it hits and what's in its way. It's pretty interesting, unlike Hollywood, where somebody is shot and they actually fall down. In reality, that doesn't happen. People get shot and they're still talking to you. What happens is that little gun hole that goes through there, that round, that projectile that goes through, is not going to knock a person down. You're going to have a lot of firepower to actually push somebody down onto the ground. If somebody is found on the ground, it's probably because they fell down because they're in pain. Now what happens is when somebody gets shot, your body has this system, it's norepinephrine, it starts flowing through the body and it tries to mask pain. So the majority of the people that have been shot will just be talking to you like you and I are talking right now. They know they've been shot. They're actually more traumatized by the situation that happened by looking at the hole inside their chest than the actual bullet hole itself or the injury. Of the injuries that I have seen, I've thought that, oh, this person's going to totally live from this injury. This is not that bad, and that person died. And then there have been people that I thought will never make through, and they do. And it does have a lot to do with your ability to hold on. If you were one of those people that say that I'm going to live no matter what, the chances are that's going to help your body immensely. And that's why it is important, as people providing first aid, not to say anything. Don't make any comments at a first aid scene. Somebody may be unconscious, but the hearing is the last sense to go. So you may be at a scene of a bullet wound or a knife wound, and you're looking at this person and you're saying, wow, this person's really bad. That person's listening to you. You do not want to interfere with that person's ability to survive, and it is. It's an internal thing that everybody has a different pain tolerance, everybody has a different threshold, everybody has a different will to survive. Some people are going to live, some people are not. Same injury, same day, different people. Bleeding, because somebody can bleed to death before they can die from breathing. We know that the brain lasts about 10 minutes without oxygen, but somebody can bleed to death in 3 to 5 minutes. So that's why we change the priority. When we do assessing people and we prioritize them in this sort of situation, we look at bleeding first, then breathing, then movement. And when we do this assessment, when we approach this person and we say that they are bleeding, as you said, arterial bleeding, which is high pressure bleeding, that is the first thing that we take care of. We don't do a head-to-toe assessment. We go right to that area and we control bleeding immediately. That is our first priority, and then we diffuse out from there. You know, some things that I didn't talk about was as far as body substance isolation and wearing gloves. It's very, very important to wear gloves. When you're controlling bleeding, the first thing you have a tendency to do is put your hand over the injury. If that person can put the hand over that injury and you have time to put on gloves, that's the way to go. Again, if you don't have that ability and it's an emergency situation and you make that conscious effort that you're going to control bleeding, look at your hands, make sure you don't have any cuts on your hands, and then apply that pressure and then wash them afterwards. I can't say that you will or will not contract anything from bleeding. You have to make that conscious effort to help that person. But you need to know that somebody can bleed to death in 3 to 5 minutes. And so the pressure that you put on that bleeding artery, that arterial bleeding, can certainly make the difference between somebody's life and death.
So if you stop that bleeding and ambulance shows up 10 minutes later and you're sitting there holding the water back from the dam, basically that could be the difference between life and death.
It's definitely going to be the difference between life or death. Definitely. You keep that pressure on there, and then that paramedic, that EMT, that firefighter, they're going to take over that scene. They'll know what you're doing, and they'll go ahead and mask over your hand. They'll put pressure over that wound. They'll put pressure over that artery. IVs are started. More fluid is going. There's a thing called mast, which is a garment that we put on people, and it puts high pressure in the legs to push fluid back up into the trunk of the body. So there's definitely stuff that we have on the ambulance that they have at the hospital to help people with bleeding.